All right, guys. Well, welcome back to the second episode of the Position Statement podcast. Just a little
Number
introduction.
two.
Number two. Oh, yeah. Every week, hopefully. We'll see what our schedules look like in the future. But
I think we can manage once a week, if not one
yeah.
every other week.
Yeah, definitely.
At least every other week at most.
For a little introduction, first we wanted to give a shout out to all of the places we're putting the podcast on, and then some of our social medias and stuff for this channel. So the podcast will be streamed on YouTube and Spotify. For the most part, we're working with Apple trying to get it on there, but it's a little funky. But for now, just YouTube and Spotify. So like I said, last week, our YouTube Position Statement podcast. We also do have a Discord for anybody that wants to go on there, post something. We can take suggestions on position statements or games or any main topics that athletic trainers would want to talk about, or anything that you would want to know about athletic training.
Any kind of questions or anything that you want to know more about, or anything, we will be glad to reach out and talk about those.
General interns, definitely.
And then the Instagram page. We have our Instagram page for the Position Statement podcast. No spaces, no upper cases, just the Position Statement podcast on Instagram. So those are the social medias that we're on at the moment. And then if everybody's good, we're going to dive right down into our main topic for today.
Oh, yeah.
I think we're
Ready to go.
All right. So our main topic for today, we're going to be talking about state regulations. So state regulations for athletic training are either hit or miss. So we all live in the state of Pennsylvania. We all have to get licensed through the State Board of Medicine through in Pennsylvania. A lot of other places that have athletic training, most states in the United States, you have to get licensed to be an athletic trainer, but they have their own set of rules and regulations that we have to follow, not only just from the BOC and the NATA, what they suggest, but they have their own. So we're going to talk a little bit about the state of Pennsylvania and what we've noticed about the state regulations, if it promotes best practice, if we can do the things that we were taught in school, because some of them we actually can't. But yeah, we're just going to have our discussion about state regulations in Pennsylvania. So the big thing that I notice, and we'll cover in the position statement section as well, but for heat illnesses. So it's a big thing that we will learn in school. One of the best practices for heat illness to try and get the best ideal core temperature for the body is actually through rectal temperature. And this is classified as a invasive procedure. So in the state of Pennsylvania, we're not allowed to do invasive procedures. Basically anything that enters the body through an orifice or through the skin or anything, we're not allowed to do. So how do you guys feel about not being able to do these best practices that we learned in school and that are on the position statements, and we're not allowed to do them in the state of PA because the law says we're not allowed to?
I mean, breaking it down, looking into depth about it, like it is concerning, in my view, I think, is that, like, we learned how to do these through school and everything, and that our state doesn't allow it to happen is it's eye-opening, because like these are the best gold standard practices to go about treating our patients and make sure they're staying healthy. That we're kind of handcuffed, not being able to do it is kind of frustrating at times, because we know like this is what we need to do to like make sure they're okay, they're not struggle, have a really bad situation going on, and that we're kind of handcuffed not being able to do is kind of hard, I feel. And it puts us in a really tough situation that we know we need to do it, but we can't, because based off the state regulations, they don't allow us to do it.
Another thing I want to say, it kind of, like, as Chris said, like, the best word to say was handcuffed. Like, we're supposed to be promoting best care, best practice to these athletes, and for state laws and regulations to kind of say, no, you can't do that. It's kind of annoying that we can't provide that best practice or gold standard when that's like what is said to do. Kind of how we're about to, as a group here in the master's program, we're going to be learning how to suture. And as Jake said before, we can't do any like invasive procedures until we're learning these things and getting, you know, the skills and knowledge of like how to do these things. It's kind of frustrating that we can't implement that into our practice if that's what we're getting taught to do and what is told to be the best.
I think the biggest thing here with like school, I mean, it sucks that they're teaching us all this, but the reason they just all this is because it'll be an all-encompassing program. Like not everyone in the world that goes to EA is gonna be practicing in PA. Like I know a lot of people are, but they gotta teach it just in case, you know, we do practice elsewhere. Because there's a lot of states, like say if I went to UNC, like I wanted to, and I graduated from ESU, I'd be able to do all that stuff. You know, I'd be able to do a lot of those invasive procedures, and you know, but it sucks that we don't get to use them here in Pennsylvania. But I think like the biggest thing that sucks with, like, don't get me wrong, I love athletic training, but the biggest thing that sucks with it is that it's not looked as legitimate yet as some other professions. And I think it's what we're fighting for. I think it's what the masters is trying to transition into, you know, with the mandatory masters. I think it's trying to get there. So I just don't think they're like, I think they think we're tape jockeys and stuff like that. We're not actual medical professionals. And that's why they're not letting us do all that stuff yet. Because I don't think they like the state and the legislation thinks that we have the skills to do this. And I think the mandatory masters and stuff like that might, you know, gain some traction with that.
I know, like, in the times changing now too, is like as more we move on to the next couple of years, like the reason like we are doing sutures and stuff like that too is they expect within the next couple of years like that we are going to be able to, that's to be
Correct.
legal under our state practice act, that we're going to be able to do that. So I feel like Liz said, you know, it's kind of hard to do it now, but like especially that we're learning it, we can't use it. But I feel like in due time, as you know, information keeps evolving and practice keeps evolving, that these kind of procedures that we can do will be legally allowed to do in due time. It's just they want to make sure it's the right way to do it and make sure that we are educated enough to do it.
Yeah, absolutely. I think the big thing though is like the sutures and stuff like that is like cool. Yeah, I'd love to do that, and I think it could be beneficial or whatever. But the bigger thing is IVs, and like we're definitely gonna get it to talking about that later. But that's the biggest invasive quote unquote procedure that I think we should be able to do. I mean, phlebotomists have like thought, like not to knock phlebotomists, but they don't have anywhere near the schooling we have, and they're popping veins all day. You know what I mean? So I think just send us to like a CEU of phlebotomy or something like that, and you know, let us get certified like that. Like we have the training, we have the knowledge, we have the skills. It's not that hard. So
I know that's sorry, Jay. I just wanted to touch base on that too real quick. I just know like it's definitely like state differences too, because I know like down south, like they do allow their ATs.
Oh hell yeah! Oh hell yeah!
Those IVs. So that's why it's
It'd
like
be
so
silly if they
frustrating.
didn't.
Especially like, you know, I just don't think they transitioned that to up north now yet, because we don't experience the high extreme heats and humidity that they see on the day-to-day basis. Like they don't really have a change of seasons. They're warm pretty much the entire year round.
Yeah, so I think we are moving in the right direction. I think starting with moving athletic training to the master's level of education, that's going to push for more of the state and national regulations to change. So people are going to say, well, what if you have your athletic trainer who went to school a while ago, like us? So we only had to complete our undergraduate to sit for the BOC and everything, but we do have to complete continuing education courses. We have to complete 50 of them every 2 years. 50, they're called CEUs, continuing education units. So we have to complete 50 of these every single year. And if these courses can include, you know, the basics on sutures and how to suture, and then you go to a conference and they have dummies set up where you can actually perform this stuff. It's not like we're never going to learn these new best practices, because the health profession is always changing. And since it's always changing, there's always new best practices. We get position statements almost every year, every couple of years, that get updated with the best practices. But everything's going to change, and it's just like every other profession trying to move up in the ladder. We're just trying to move up in the ladder and be noticed by our politicians and everything, state regulators and everything, but also by our patients, explaining that, hey, I only have a bachelor's, but I know all this information, instead of saying, hey, I'm a master's level student, I have a master's. It can be beneficial to those people and say, hey, I have this education, I know what I need to do, and I'm going to help you get through it. So
Another thing
So
I'm gonna say off. Oh, sorry, Trevor.
go ahead. No, go ahead. Go ahead.
What you said about how like we want our patients to like kind of recognize like the skill set that we have, is actually funny because I've had to explain kind of like what we explained last week about like what our profession entails, but I've
Did
had
you
to
just tell
explain.
them listen to our podcast? That's what you told them, right?
Well, this was before this was made, but
Okay.
I would have to explain everything. And actually, one of my friends' moms, they like were questioning me, were like, "Oh, like that's not what I know them as," and I'm just like, kind of how Jake just said, like our profession is always going to be growing into what it's going to be as science changes and like as you said, politicians recognize like our education and whatnot. So I kind of lost my train of thought there, but honestly, Trevor, just take it away. I totally lost my train of thought. But basically, what I'm trying to say is like once people recognize us more, I feel like we're going to get respected enough to do those practices and what we could segue into. And one of like these, I saw a sticker the other day. I was at the NATA conference, and it was like, oh, certified to run with scissors. And I was just thinking there, I was like, really, really, like kind of made me so mad. Like that's like what people look at us as. You know what I mean?
Yeah, it's definitely the like the blanket term for us or whatever you want to call it, the generalization. You know what I
Like
mean?
tape and scissors,
Yeah,
and it's just
Mhm.
exactly.
like that is not what we do. And like everything that we're getting taught behind the scenes, like as I said, we're going to be doing suturing, we're going to be doing all those things, and we like learn a lot of like gold standards in our education, but we aren't allowed to implement them. And that's why people don't see what we could do, because we're kind of, as Chris said, handcuffed. We can't do those things, so people aren't going to see what we can do or the skills that we can, provide, or the care we can provide through our skills and stuff. So
I was gonna say, like, what do you like? Speaking of like legitimacy and stuff like that, when you're trying to explain them to your patients or to, maybe a patient's parent or something like that, like, what speaks more volumes? Like, growing up for me, I was always like, I trusted the guy who did the job for 10 years, even if he only has a bachelor's. Like, I trusted that guy a lot more
yeah,
than like somebody who's at an entry level master's. Like, like it's so funny how people look at it like that way. Like sometimes I'm willing to bet people will get hired. Like you could be in the field for 12 years and I'm willing to bet some weird HR manager is probably going to hire the kid who has the master's fresh out just because they have a master's degree, or maybe they went to the same college together. You know what I mean? Like it's not nepotism, but whatever you want to call it. It's just, I would think that the experience says a lot more than maybe like if somebody, I don't know, if somebody's in the field for 15 years, I would trust them more than I would trust, you know, an entry level master's.
I
yeah,
have to agree with you there too. Is like yeah, they have the higher education, but education is not the only thing that makes you who you are as an AT. Like you
Think about how
having field
grown in your
experience,
clinicals. Like
yeah,
how much did where the growth took place in clinicals, not like if I'm doing like those weird like evals on other like patients in like Torres's class and stuff like that, like the real growth and stuff like that was out doing real evals with real patients.
yeah.
uh, so with all these new regulations and stuff, I know one of the big parts is that we actually have to go to our state regulatory body and push for these items on our agenda. I was fortunate enough to go to Hike to Harrisburg. It's a campaigning event to promote the profession of athletic training in the state of PA. And I had a great time there, networking, and everything was good. But it was actually really cool to see all these athletic trainers come together and say, "Hey, we should be able to do this stuff. And if we aren't providing that best care that we promise our athletes and our patients." But being properly trained for all of these things that we're going to be doing is a necessity. So, like Trevor said, taking these CUs, like if we're going to take something for IVs, take something with a phlebotomy course or anything like that. We do have to be specially trained in some of these areas that we are going to be doing. If we're going to do sutures, we don't learn every single type of suture that we should be doing on the field, but there's a possibility for us to be able to learn these. So going with that, there's a tier list of how our regulatory practice works. So we start off with how the BOC says this is what an athletic trainer should do. This is your entry level athletic trainer. This is what they're allowed to do. And going down from there, each state has their own practice guidelines. So in the state of PA, we have our own practice guidelines that the state regulators look at and say, hey, this is what we think they should be able to do. And this is what they're going to practice in PA. And then after the state regulatory guidelines, we go down to our physician orders. So it's kind of, I don't want to say a get around to our state practices, because our state practices are there. Some of them might be a little goofy, like the invasive procedures and stuff for some people. But in our physician orders, if they say we're allowed to do things and they've seen us do these things, for say, like the rectal thermometer, it's our best practice. And we're eventually going to need it at some point, and we're going to eventually have to do it. If our physician knows that we have the competent training for it, and either they've seen us practice it or they've gone over it with the physician on how to do it and everything that you need to do to be trained on it, the physician can allow you in their physician orders to use that best practice or use that practice that they're doing. So I know at a lot of colleges and stuff, maybe not in the high school, because that gets a little finicky with the rectal thermometer, because the high school minors. But in the college level, these athletes are hardcore college athletes, and to give them the best patient care, we have to give them the best practices. So if that rectal temperature is going to save somebody's life, then it's a must do for us as athletic trainers. And a lot of colleges put in their physician orders that rectal temperatures are a good thing and that they're allowed to do them. They train with the physician on how to do them, and they're able to use them. I know at one of my clinical sites, they were trained on how to use it. We had one in our kit. We were ready to use it whenever we needed to. And that was that. It's the physician order. He said, we're allowed to do it. We're going to do it if it's needed.
So even if you don't give us like rectal thermometer, like, because like people listening to this podcast will probably think like we're pushing to stick something up someone's butt so hard. Like, we're not. We're doing it because like we truly care about our athletes, and we're doing this. Like, athletic training isn't the best paying job on earth, and we all went into a lot of debt to do this because we truly love it. But if you're not going to give us, rectal thermometer, at least give us IVs then. You know what I mean? Like, you can't give us one, give us something to help us save this person's life as soon as possible. You know what I mean?
Another thing I want to say on that is we're looked at as like first responders too to these like emergency incidents. So like if we're not allowed to do basically all things that
the first responder stuff. Yes. Yeah,
exactly. So like why are we called that, and is that in our job responsibility if we're not even allowed to do half the things that
why do we learn e-care if we can't do it? Exactly.
That's like kind of like confusing to me, that like we are supposed to be the first on scene, we're supposed to do our primary assessment, blah blah blah, and basically make sure that person stays alive till EMS gets there. But how are we supposed to do that when the things that we need to do are illegal or not in our physician's order?
And especially like comes down like you said, like we're first responders, but like the only thing we really could do is like a cold immersion tub to get their temperature down. And like at the end of the day, like that works. Theoretically it does work, but if it's in a high situation, like a really stressful situation, and you need a more advanced way of doing it, and that's the only thing we can do, like it's kind of hard. Like you can do more, but like that just handcuffs you, as we said, and just comes down to is like why stop us from doing the best we can do when we know is the best that could possibly save their life.
Yeah, and what if a life is lost and you knew you could have done better, but your laws said no?
That's an interesting conversation.
And you have to live with that, knowing that you could have done more, but legally
you have to live with that. You no longer have a job. trust me, somebody dies in your care, you're done. Your license is gone. Doesn't matter what the thing is, you're done. Just like look at the Maryland people. The kid died in Maryland. Like they're done forever.
And that's so scary because like you're sitting there knowing you can do more and you could do better than what you're doing, but like you just can't. So like you'll lose your job either way. Like that makes no sense.
Yeah, I don't know what to. All right, so maybe like quick little discussion here. What that situation arises? What are you doing?
I mean, no
Honestly,
matter
It's
what,
on the line. It's not in your physician's orders, but you know it's the right thing to do. What are you doing?
I
I
would
would-
I don't think I'm
honestly-
doing it. I don't think I'm risking my
Yeah.
license.
all right, Liz, you go first.
So as you're saying, if someone dies in your care, you're losing your job. Blah. Okay.
Yeah.
Well, I would rather if it came down to life or death and I had to do either something that's illegally as a procedure to save someone's life or just let them die knowing I'm going to lose my job anyway, I'm doing the procedure. I don't give a shit.
Yeah.
Like I'm not going to watch someone die on my care if they're in that critical condition and like their life's on the line. Like I'm not going to be the person like between their life and dying. That's not what I'm going to do.
Yeah, I have to agree with Liz there too. Is like honestly, like, personally, like when it comes down
Dude.
to it, I would do my best to do everything by the book legally that I'm allowed to do. But it comes down to it, like I just like morally speaking, like, I would rather lose my license than to have someone die in my hands when I know if I did this something that's I'm trained to do, but legally not allowed to in my state. But if I was in a different state, I would have been legally allowed to do it. I would take that risk and somehow, go through the court and everything, like go through the hearing and everything to see if I lost my license. But knowing morally that I saved this person's life because I did what's personally right, that and morally, I take that risk because I don't want that person to die and have the guilt of losing an athlete and the guilt of like not being able to save him for his parents and his family. Like losing that is like I can't imagine that. So I personally would take that risk and do everything possible to make sure this athlete stayed alive.
Now I have a question before somebody else goes, but if you are following the law and you did everything by law that you could do to the highest extent and you still lost them, would you really lose your license if you did everything you had to do?
No, you
I
wouldn't.
feel-
You probably wouldn't lose your license, but you'd lose your
I
job
don't-
for sure.
I
You'd
don't
get fired.
think so.
There's
It
no
just
doubt in
comes
my
down
mind.
to like there would be a whole like court proceeding about it probably
They would definitely let you go.
because it's a death on your hands. So like obviously there'd be like a hearing about like through the courts probably.
Yeah,
And, like,
and you're
Well,
gonna get sued
the-
no matter
Well,
what. Like their family's
here's
suing you.
here's something that like confuses me then because I not gonna say anything, but I know somebody that had an athlete die of a head injury during a
Holy
football
shit.
game, and they did everything they could, and they still died, and he still has a job.
Was
So,
it Second Impact?
no.
I mean, I guess it just comes down to
Second Impact, he's fired for sure. Like that. That's
Well,
why I
yeah.
asked.
Yeah, no, but it was just such a bad injury that they got rushed to the hospital, couldn't be saved, like literally like died on
I
the way to
just-
the hospital.
Yeah, I just think it comes down to what you did. Like it comes down to like they'll review it, they go to the boards and everything. Like they'll review your statement of what happened and like go through all the information and decide then like every situation is gonna be different. Like some people might lose their job in that situation, some might not. I feel like it just all depends on what they rule.
Yeah, and another thing is like it was preached and like ingrained in our heads to follow the EAP through and through. And I feel like if we follow that as well as following like what we're allowed to do to the highest extent, I feel like there's no reason that we would have to lose our job because we did what we had to do and we followed everything correctly. So I mean,
The reason I said
it's just kind of like
like an example of like you look at all the exertional heat illness, like one's lost their job. You're like when you like read that like D-line guy, whatever, Edmund died, guy in Florida died, guy in Alabama died. Like that was talking about those instances. I'm sure there's instances where like somebody did the best they could. You know what I mean? Like it's probably the person
Yeah.
probably did the best care ever, and obviously he wasn't at fault, but maybe heat illness, deaths. Those people are
and
probably at fault.
I see it happening in a lot of like bigger settings, maybe like a high college setting, because you're gonna see those deaths a lot more. They're gonna be more big in like social media than it would be like if that happened at a high school. And I feel like that's when like those ATs probably get a lot of heat from like the organization itself, and that's probably why they get let go.
That makes sense. Yeah, that really does. It's way more high profile. You're right.
Yeah.
So for me on that topic, I mean, I'm gonna follow state and national and physician orders to the T. I mean, I know it's a conflict of moral interest for myself, but it's also it's what I know at the state level sometimes it doesn't make sense because obviously we talked about the invasive procedures and stuff, but in our physician orders and the BOC, they know what we know, and if they're not comfortable with us doing that stuff, obviously I think there's a reason for it.
Yeah.
And that's just the biggest point that I wanted to hit on is if it's not in my orders, I shouldn't be doing it, and I'm going to follow that because there's somebody over top of me saying, hey, you're not ready to do this, or this isn't in
Yeah.
your scope of practice. And I understand losing the athlete or the patient is tough, but then again, I'm not I'm not going to get in trouble with the law or anything, but it's going to be a conflict of moral interest for me to handle that situation, but I got to do what I have to do. And
I have to
Yeah.
agree with that.
I
Hey,
honestly
I
do
got to do
agree
it.
with that. I do agree with that because I don't think there'd ever be a situation where if you did everything you could, besides maybe as I said before, like the college setting where it's like high profile, like you might lose your job. But I feel like personally, like I would do everything I can legally to do that, to help the patient and try to like, keep in my realm of and like scope of practice. I definitely agree with you, Jake, and I would do that first. But ooh, that would be so hard. It really would be so hard
Yeah,
because like,
let's
I
pray that doesn't
agree.
happen to any of us.
yeah,
It's hard to deal with, and being in those situations, like for instance, I've been in one of those not a tough decision instance, but in those life or death situations. I've been in one of those at one of my jobs, and all you guys know about it, but it's real tough on, not to go back to the mental part of it, but you got somebody's life hanging in your hands. And as healthcare professionals, we know that every day we're going to have people's lives in our hands.
We signed up for
And
it.
yeah,
that's what we're doing for our profession as healthcare professionals. And we're going to be saving lives. And sometimes there's lives that can't be saved every day. But us as healthcare professionals, I think we have to know that. And that's one of the big points of our job. So
and I think this is what like this whole conversation is a big reason why we have to advocate for our profession, so we are able to do those things, so we aren't in that position where we have to pick
Mhm.
and choose and like feel morally wrong. Like if we have the tools to do it and we got trained in it, we'd be able to like not have to think about that.
Yep, I totally agree
Yeah,
with
just do the
Yeah.
job. Just do what we have to do to
that. Mhm.
get the
Yeah.
best outcome.
Yep.
And having those gold standards in the back of your head, just sitting there lingering, knowing you can like how to do them but you can't, is like the really like shitty part about it.
Mhm.
Yeah.
And that's like when you're acting in a situation that's like, as I said, life or death, like it's gonna be hard because like you know how to do that, but you just have to choose not to because you'll get in trouble.
Mhm.
It's funny that we got really deep into this, but like I'm sitting here thinking like, what can't we do whatever situation will we be posed in that this would happen though? You know what I mean? Like, what can't we really do that's really going to save somebody? Like try to think of an instance that like what we
There,
can't do in PA is going to save somebody. Besides,
yes, I agree.
that's probably won't.
There are the basic things that we know, like to do CPR and first aid and AEDs and stuff like that. We're all trained on that, and that's all in our orders. But there are other ways around to doing best practices. They're just not the best practice. So, with IVs, and going back to the situation with Chris
Or
saying,
EpiPen. Yeah, those
and
EpiPens too. Yeah.
so
I mean,
that's
we
another.
get around
On
with
that one, right?
So we're technically not allowed to administer EpiPens when anaphylaxis shock is happening to a patient. We have to.
Which is crazy.
We have
That's yeah. See,
to.
that's
That's
the one
so
instance I was
stupid.
thinking of.
We have to
Well,
put
we
that
all know how to get around
EpiPen.
that, right?
Yeah, we put the
Yes.
EpiPen in their hand and we
And grab
Yes.
their hand. Yeah.
Yep. But there are other ways around it, just like that. So to say that we have to lose somebody because we haven't used our best practice, there are other ways around doing best practice, but those are the best ones that we have the highest probability of, saving a life or increasing odds.
I
So
think the EpiPen thing is kind of silly though, because
mhm.
that's just like saying like, oh, like as you said, like, oh, we put the EpiPen in their hand and they put it, like we like use their hand to put it in. That's like having them put like a rectal thermometer right in their hand and be like, yeah, here, put it in, like,
Mhm.
or like an IV, just shove it in your arm. Like that's so stupid. That's
Yes.
Well,
so
I mean,
silly.
what about reductions? It spontaneously reduced itself. You know what I mean? It's all about how you write it up, really, is what goes down.
All right. Does anybody else have anything to add to the main topic? We're gonna get into the heat stuff again. So anything else
No,
for
I'm
No.
cool. The
state practice
No, we're
little
good.
break.
Little break.
Yep. I'm gonna take a couple minute break, more specifically because we're on Zoom and I don't want to pay for
Premium.
premium
I mean,
Zoom.
maybe if anybody has a hookup at Zoom, we could get that
Yeah.
premium.
That would be
Yeah.
really nice.
That topic got me heated.
And maybe some like
I need a
video
break.
editing software. What else can we get?
But yeah, so we're gonna take a little break, reset the Zoom, and then we'll be back in a couple minutes. Won't be too long for you guys. So
And we're back.
For the 5th time.
A little bit of technical difficulties there, but we figured it out.
after
It was
Trevor's router reset.
It was mostly Chris's fault, though.
My
Wow.
fault. I didn't have any issues with my recordings.
All right, so we're gonna get straight into top 3. This week on top 3, we're gonna do athletic trainer tools. So we classify these as, or at least for today, non-expendable items. So anything that you don't throw away after the second or after the first use. So anything that we use on the field in rehab or treatment, anything that we use for evaluations, anything like that, all up for grabs. So Trevor, take it away with your top 3 for the 5th time.
I think it was only this is like the 3rd time, but anyway. So like I really couldn't bring it down to just 3. I mean, I'm gonna give an honorable mention. I'm gonna do my top 3, then an honorable mention. So I really like the Shark. I know Liz is gonna combat me on this one, but I love a fresh Shark, a fresh blade. You throw it in there, one that's not gunked up with tape, or you take the little bit of tape
Yes.
remover spray and then you wipe down the blade a little bit. You know what I mean? So it gets nice and sharp and good. Number 2, Game Ready. It's an absolute machine. I love that thing. I think every training room should have one. Make the money, do a fundraiser, wash cars, do what you got to do, get one. And number 3, I know a lot of people call it different things, but for this sake, we'll call it Graston. I know you got to be certified in specialty Graston to be able to use Graston's tools, but scraping. I know there's a bunch of different tools out there, Technique, Gavilon, and a few other brands out there. They don't really need to be certified in to use their tools, but I use it all the time in my clinic. I like to pair it with stretching and cupping as well. But those are my 3 favorites right there. An honorable mention, I love golf carts. They are so fun to whip around. The kids always want to drive them. It's so funny. They're great. They're amazing. I love them. Next.
That's awesome.
All right, my top 3. So I got a weird list, but
Oh,
it's totally
Jesus.
fine.
I'm
I made
intrigued.
the idea topic, so I've had a lot of time. I think since it's been a week to go over these things. So I'm gonna go reverse order of my top 3. So 3rd, ice machine. I am a big believer in ice, for 1, swelling, but 2, pain. So it doesn't help decrease your swelling, but it helps stop new swelling from coming into the area. That's a big rumor about ice, but I like to use it for pain. Great pain management skill, therapeutic interventions. That class was amazing. So Ice machine, big on the ice.
Amazing.
What?
Really?
Hey, don't shame him. It's his list. Back
Yeah.
off.
No, not the ice machine. The therapeutic modalities.
I love that class.
Oh my Lanta.
See, it helps when you
Oh,
have a
my.
great lab professor for it.
Yeah.
So,
Yes. Anyway.
especially one that teaches it very, very easily. So, second favorite, I gotta go with a pen light. I don't know why,
Okay.
I'm
Interesting.
listening.
but I just find pen lights, like how you press down the clip. That's so intriguing to me. And yeah, it helps with your concussion diagnosis, but whenever I'm sitting on the sideline, I always have my pen light out and I'm clicking that all the time. I don't know why.
Then his batteries go out and you can't use them when the guy actually gets hurt.
That's why I always got to carry two strapped on you.
Double pen
All
lights.
right, Jesus.
All right, so pen light number 2. I don't know why. It's just a weird favorite of mine, though. Number 1, this is my number 1 upper body rehab tool.
Oh, I know where this is going.
I do too. I know it.
Body
the-
blade.
Let's
Drum
go.
Yep, there it is.
So, quick backstory why they all know this is because in one of our classes, we were doing rush, like, I don't know what to call it, like
I
a
think it was
rush
2 minutes. Yeah, 2 minutes.
rush
you
to
had.
find equipment to do a rehab exercise thing program. And I had an injury that I was dealing with at one of my clinical sites, and I knew exactly all of what to do. I followed their program to the T, and I brought out the body blade and did some, they're not ridiculous stuff. It's just stuff that I've never seen before going to my clinical site. And I loved it. It's so good. You can do from wrist to shoulder to anything upper body, basically. And it's just a great tool. So,
Needless to say, Jake won that challenge. Didn't you? I'm pretty sure you won that one.
yes.
Yeah.
Yeah.
Yeah, the crowd went nuts for the body blade.
Yeah.
The D1 and D2 flexion patterns.
the
Oh
crowd
yeah,
goes
they
wild.
went nuts.
But yeah, I didn't actually use the body blade because I couldn't find it. I remember that now. I couldn't find the
You
body
used, like,
blade.
a
It was
stick,
behind.
didn't you?
Yeah, I used the
Here's the-
pole
Here's the poll.
because the body blade was behind. It fell down behind the rehab cart behind the door with all the weights on the side and inside of it with the ankle weights. It fell back there and I couldn't find it. But yeah, so body blade top 1. But who's up next?
can
I'll
go.
go.
Oh,
Okay. Ladies
Oh.
first.
okay. Okay, so I guess I'll go third to first. So third, I'm gonna say pulse ox, because I feel like that tells
Mhm.
you a lot about like what's going on with your patient in, when you need to use one. It could obviously tell you if they're going into hypoxia. It could tell you like what their pulse rate is if it's not coming down. You know what I mean? So like that's a really good tool to have, and I've used it multiple times on athletes, and I think it's very useful. Second thing, kind of random, but like whether it be a Bosu ball, an Arex pad, those pebbles that we use at ESU, Christian, I know what I'm talking about. Anything balance related, because I feel like if during rehab, if you work on balance, it's going to prevent a lot of injuries from happening. So I really like incorporating a lot of balance into my rehab, and I just love that type of training, and I love those tools. So I guess anything that has to do with balance. But my first, this is going to be an at everybody here, but I like just regular shears or scissors, not the shark, because scissors are so like versatile. You can use them obviously for taping or whatever. That's like what we're going to use them for the most. But like they come in such like handy times when you have to do like an emergency, like rip down the athlete's jersey, whatever it is. There's so many different ways you can just use scissors, which the shark can't really do. So I'm gonna stick to my, OG scissors. So that's what I have to say.
Hold on, Chris. Sorry.
No,
Going off
you're
of
good.
what Liz said with something about the scissors, but I have to give an honorable mention to Rydell for the Rydell helmet quick release.
Oh, okay. The little
True.
thing you press in there.
Yep. That thing
The
is
red one.
Yep. That is a very useful tool, so you don't have to, cut open a helmet to access their
True.
airway if a
Mhm.
football player is unconscious. That quick release tool saves so much time and effort going into taking a helmet off.
Very
I just
true.
wanted to add that.
All right. Well,
Chris?
going to mine. I am a big therapeutic rehab guy. That's kind of like where I want to do like kind of a specialty, and so that was what my list encompasses. So at number 3, I mean my 1 and 2, or my 2 and 3 are kind of similar, but they're different in essence. But number 3, gotta go with the Normatex.
Okay.
I used them once when I was at my rotation at ESU,
Oh, they're dope.
and if you don't know what they are, they're just vacuum like leg splints to help with blood flow and circulation and get like soreness out and everything like that. Our athletes love them, and so I had to try it out, and I fell in love with them. And I will try to make sure and later on in my career that I will have those for my athletes, because especially like runners and stuff, I feel like that they're very beneficial if I'm able to get them. Um, the number 2, I gotta go with the Theragun. Same kind of thing, massage, but I think that's so versatile for like any kind of athlete in essence of warming up their body. Like I know a lot of the football players would use them religiously, on Sundays after a game day. So it is kind of tedious and annoying because we had to do it for them. Like we weren't allowed to give them to other athletes to do it for them. We had to do it. So it did take some time, but you know, me working in the college, like that's what I want to do. Like I talked about that in our first episode. So it really, I don't know, it's kind of different for me. A lot of people hate to do it, but I honestly really love it. But number 1, it's dear to my heart. I've used it most of my life, being a baseball player. Is an e-stim machine. I know a lot of people don't tend to like it because they, it can be complicated at times to know what settings to put it on. But I find it so enjoy like you. I love using it. I think it's really a key factor for rehab and going based off like recover from injuries or soreness or anything like that. Like I know we use it a lot. Russian stim for our ACL reconstruction athletes, and then re-education of muscle to get backfiring and everything. So that's my top 3.
Nice.
All right. So after our top 3, we go into our position statement for the week. So our position statement is trying to line up with our main topic for the week. But this week we're going to be looking at exertional heat illness. This is a big thing for fall sports that have summer camps in August, and looking at exertional heat illness, it's very prevalent, especially in a couple sports that have equipment and everything. But we'll get into talking about that. So we have a couple things lined up for questions that we're gonna answer. So first one we'll start off is, what actually are heat illnesses? What different types of heat illness can you get? How do they occur? Which ones are most common? Stuff like that. So whoever wants to, take that into their perspective, take it away.
All right. So I mean, as you said, we can go over different types. Obviously, one of like I think the most common is just like muscle cramps. Like it's gonna be like
Mhm.
just cramping when maybe they're too dehydrated because of the heat. When there's high like temperatures and such. Um, what's the word I'm thinking of? Like the evaporation of water gets higher, which goes into humidity and such too, which we'll
Mhm.
probably talk about. But making sure your athletes are hydrated properly, before, during, and after is going to help against or prevent muscle cramps and stuff like that. Um, Obviously, heat syncope, exertional heat exhaustion, heat stroke, um, all
That's
those
all of them.
two.
Not
Yeah,
all of them,
and
Yeah,
but
that's pretty
yeah,
common.
that's the list.
that's it. I was trying to think. I think there's no more. So
So we got muscle cramping, heat syncope, heat exhaustion, heat stroke. Those are the top four that we normally see with heat illnesses. So going into heat illnesses, I know, Chris, you worked with football as well as I did. Football is a big one that especially the NCAA and the PIAA try to prevent with football. So during the summer, we have to have either, I think PIAA is 1 week and then NCAA is 2 week. I'm not totally sure on that, but we have to have a what's called heat acclimatization camp. So it's regulated by the state and or the NCAA, the national committee, but we have to have these practices that are timed for a specific time. They have to have so many water breaks in between and everything like that. So looking at football, Chris, why do you think that football is one of the most important sports that we have to watch for heat illnesses in?
I think, it is, I believe, one of the most grueling sports that you can play, honestly. Just to go off, like you have all that padding on that's restricting your, airflow across your body and everything like that. And it's not just like they go and practice and stuff. Like they have morning lifts, like they have afternoon lifts, they have walkthroughs and everything like that. And like they're burning so much calories and, sweating so much that like rehydrating after everything and making sure that they're hydrated. Like I know ESU takes that into account. Like they talk with their nutritionist and everything like that. Like make sure like every athlete knows how much water they're supposed to be drinking and everything like that. And it's kind of hard too. It's like some athletes don't realize how important hydrating is. Like I've heard of an incident like this one kid, he was a lineman and he wasn't hydrating enough, and they were staying in the dorms that were not heated or not air conditioned as well as they should have been, and he got like really sick, and he had a lot of issues. So I just think hydrating as a football player, I think they don't realize how much they sweat, and being rehydrated and everything like that is really a big factor into making sure they're fully able to participate in their full at their 100% capacity.
So I know when I worked with football for a semester, we the athletes at that specific school would have to weigh in pre-practice and post-practice. And I don't know if they did this at ESU, but I think it's a really interesting concept where you weigh in pre-practice and post-practice. You have to get up to the same weight or higher the next practice, or you have to be in within a certain range of your weight to be able to practice the next day. And if you were too low on that weight, a lot of that is water weight that they're going to lose. They're not going to lose a whole lot of fat mass during just one practice. If you're not going up to that weight that you're at pre-practice, there's obviously water weight that you're losing, and you need that for your system. So I don't know if they ran something at ESU kind of like that, or
Yeah, I personally don't know exactly because I never got to witness that, but I'm pretty sure 100% that they in some capacity did perform those kind of protocols with their athletes. Because like you said, like we understand like everybody's body is different, so everyone's gonna react differently and sweat more. Like especially like linemen are gonna sweat more than probably the kicker.
Mhm.
Like because there's it's just the way their positions are entitled and enrolled. So making sure like they adequately are drinking. I know there's instances that I've heard that these players thinking drinking Pedialyte was going to help them become more hydrated when really that's probably worse off for you because it's going to dehydrate you more than anything. But just being conscious and like knowing how your body reacts to stuff, and like, it's not a perfect science for a lot of these kids or athletes, but as time goes on, they'll understand it a lot better. But
Mhm.
just being really hit on that home hard, like, and make sure you're drinking adequately, and knowing your body when you need to take a break.
Mhm. All right. So, Trevor, I wanted to get you in on this, see what your perspective is on it.
Yes, sir.
So what would you do in your experience to help prevent a heat illness from occurring in an athlete?
From occurring in the first place.
Yeah. Trying.
So obviously, an insane acclimatization, is that the right word?
Mhm.
Yes, acclimatization.
Yeah, acclimatization. Okay, an insane acclimatization procedure. I think the PIAA, like you touched on earlier, not PIAA.
The NCAA.
Yeah, well, PIAA for high school, and then
Mhm.
the NCAA for college. I think they have a pretty good one in place. I mean, the big thing is, I would preach to my athletes: don't sit on your butt all summer and then expect to come out and
Mhm.
go hard during 2-a-days. Well, we
Yep.
don't do 2 days anymore, but during camp. So that's insane. That's why most of it happens, because they sit around all summer doing nothing and not even doing any type of workouts and then just going right back into it. So trying to keep my athletes in shape over the summer would probably be a big thing. And then obviously just an acclimatization procedure and education. You're feeling bad. You're feeling something. You gotta take a break. You gotta take a breather. You gotta
Mhm.
stop. You know what I mean? And just educate your athletes, on the signs, the symptoms, what to look out for. If you're not feeling well, take a breather. And obviously water breaks, mandatory water breaks, not this insane 1987 coach thing where like, nope, you run more hills, water's for babies. That's how people die. So we're not
Yeah.
doing that.
And
I was
that's like
actually just gonna say something on that. Sorry, Chris, not
it's
to
okay.
cut
It's
you
okay.
off,
You're
but
good. You're good.
back to like what Trevor just said. I feel like one thing that we like kind of have to do as ATs is like make sure the coaches are giving those breaks, because sometimes they just want to run their kids into the ground and make them like mentally tough or whatnot. Like that's not the way to do it. Another thing that I wanted to answer something off Jake's question was obviously doing like physicals, knowing the history of each athlete, if they are
Mhm.
prone to heat illness, if they've had history of heat illness.
Sickle
Those are the
cell.
yeah, that too. Like you have to make sure that these athletes don't have underlying issues or a history of these types of problems, because those are the kids that you got to watch the most and make sure that they are getting the right hydration, the right breaks,
Mhm.
and going through the acclimatization process correctly and just thoroughly, because those are the kids that are probably going to have that episode again.
Yep. I'm a big believer in education for our athletes is probably the biggest preventative and treatment option for them. So if they don't understand what they're doing and why they're doing it, they're not going to want to do it. And
True.
they're going to say, hey, this seems stupid. I don't know why I'm doing this. I'm just not going to do it. But if we educate them
Yeah.
on, we don't have to use the terms that we do in school or anything, but giving them a sense of, hey, you're doing this for a reason. This is why you're doing it.
Yeah.
You got to do it. But I believe that education is one of the biggest preventative actions that we can do for athletes, especially in high school, because they're at that age where some of them are trying to be cool. I don't want to do rehab or something, but
Yeah.
if we tell them, hey, this is how you're going to get back to your sport, and if you do this, you're going to get better. So I think education is a good one.
To play off that, the education thing, like what you just said with how kids are like, why am I doing this?
Mhm.
You have to think like some kids that are just starting off, maybe like as we were talking about football, for example, if they're starting off and I know like days like 1 and 2, I think it's like they can only wear helmets or something.
Yep.
They're gonna be like, why am I like not padded up? Why aren't we hitting? Why aren't we doing the cool stuff? Why aren't we actually practicing? They're gonna think like this is stupid, like how you just said, like, and they're not gonna know why they're doing it that way, and they're just not gonna care.
Mhm. Oh, yeah, I totally agree with that. So moving on, second to last question that I got written up here. So we talked about this before, um, but how are we supposed to be diagnosing these heat illnesses? What signs and symptoms are we looking for? What instruments can we use to tell, what the weather's going to be like? This is also a preventative item as well.
Sling psychometer.
Yep.
Football globe waiting to say. I challenge somebody to say that 3 times fast.
Absolutely not.
Nah, I'm good.
Somebody tried.
maybe
I heard
maybe
somebody
another
start
try.
to try there.
Oh God,
Maybe another.
Trevor, you do it.
Sling psychometer, sling psychometer, sling psychometer.
You fumbled the third one.
I sure did.
So yeah,
But,
what are the things that we can use to, help diagnose these things or help prevent the, these occurring in our practices?
Just like Trevor said, like I know I've seen a lot of at all my clinical sites, they've used the wet bulb thermometer. Like that takes in effect of wind and temperature, humidity, and everything like that affects the weather, and then based off those numbers, where there's an issued chart based on like how they should be practicing based off of the humidity and the actual temperature. So it's not like the thing is like that's like I feel like is oh geez, I can't think of the word I was trying to say.
Misconstrued?
Yes, misconstrued. It's not like the actual temperature that is the scary part. It's actually the humidity that actually increases the risk of heat illnesses that occur.
Yep.
So like we as ATs, like, we really have to hone in and like make sure we have that set up and we understand and communicate that with the coach so they know like how many breaks they're supposed to get. And like obviously I believe Liz talked on it before, like not every coach wants to follow those guidelines. They just want to run, keep going and get through the practice. They think going through it quicker is going to become better. I'm like, in reality, like you're just draining your kids and you're getting worse practice out of it. So like,
Yeah.
I just feel like that's a big thing for us. That's what I wanted to talk about before. But educating the coaches too and letting them know like what we're witnessing and what we're experiencing and understanding, and just to keep the good basis of communication open so like they understand where we're coming from, and it's mainly for the safety of the athletes that we're concerned about.
Yeah, another thing for like risks and stuff and how to prevent, make sure like the kids aren't wearing like a lot of like excessive clothing that could be heavy on them, or just making sure they do have that correct acclimatization, and looking at the environment, just making sure it's not like poor conditions to be working out in and exercising in, and that all goes back to using that like wet bulb temperature and whatnot.
So for the last one, we're gonna look at how do we actually treat these heat illnesses, whether it be going from a muscle cramp or we get into a serious situation of heat stroke. There's a lot of different ways for each situation that we can try and fix these things. So I know I wanted to talk about heat stroke with how we treat heat stroke. Big believer in ice. There's another reason why I love ice.
Yeah.
The cold immersion tubs. So when I was at my clinical site, we had 5 cold immersion tubs ready to go, packed with ice for practice. And obviously not obviously, but we didn't need all of those for practice, and they were used after for cold tub immersions to cool the body down and stuff afterwards. But those are acute care instances where, hey, we need to cool the body down really, really fast in order to preserve our organs. So when you have heat stroke, the reason why it's so deadly is because your core body temperature is so high that it actually, basically in layman's terms, starts to cook your body from the inside. Yeah. So when we have that internal temperature of above 104 degrees, we need to cool the body down as quickly as possible for it to not hurt the inside of the body, hurt our organs, hurt our muscular system, our nervous system. So the cold immersion tub is one of my favorite things that one to set up. But looking at it, it's just like, this is such a simple solution to a complex prognosis that we can use. You literally take ice and water, and it can it can save somebody from death. So I just wanted to hit on cold immersion tubs, but
Yeah. No, and another thing with cold immersion tubs, like they like as much as they are simple to set up and stuff in an emergency situation when you're doing this, there is a lot of like monitoring that goes into it though too. Like I know like the water has to be between like I think it's like 35 and like 60 degrees or something like that.
Mhm.
And you have to like keep monitoring their temperature to make sure that their temperature is actually going down. And when it gets back to that core temperature, you don't want to leave them in too long because that can actually lead to hypothermia. So you have to keep monitoring their temperature as well as maybe their like CNS function, make sure that they're still, coherent and whatnot until EMS arrives. Make sure they don't go into shock or anything like that either.
So with the other things, the cold immersion tub might not be, the best thing that we can do. We have small heat, not small, but
Minor, like more
minor
minor.
minor heat illnesses such as muscle cramping or heat cramps, stuff like that. So with that, we don't really want to use a cold immersion tub because obviously the cold is going to exacerbate the muscle cramp. But in that instance, when you have a heat cramp, it's just you're looking at just the muscular body instead of the entire body itself. So what I like to use is, throw a little bit of heat on the muscle cramp. It's just like any other muscle cramp, almost. It's just a different way of occurring. And I like to do some myofascial release and massage for it as well. So on the sideline, somebody gets a muscle cramp or a heat cramp, you're trying to stretch that out. You're trying to relax that muscle in any way possible. And I think myofascial release, even though it's really, really painful,
Yes,
it
is.
it's a great tool that I love using in my everyday practice. You see people come in with knots in their muscle or something like that. Their muscles are just tight, and using that myofascial release, I think, is a great tool, and I'm really glad that we learned so much about it. So
I also know that doing like a high sodium like snack or something like that also helps with those too.
Yeah.
Chris, we had it at Stroudsburg. What did I bring on the last day?
Pickles.
Pickle juice. Yeah,
pickle juice.
Yeah.
And what actually I learned it too. Packets of yellow mustard. There's a lot of
I
sodium
learned
in
that
that
too.
too.
Yeah.
High sodium contents.
I would take those when I did my when I was doing my races with my dad. Oh yeah, what are they called? Whatever. I was doing Spartan races. That's what it is. Spartan races with my dad, and other racers were using it, and like that's the first time I ever seen it. And like actually, the person I was talking to was an ER doctor, and he was talking to me about it. I was curious at the time, like why would mustard be a good thing? And they just talked about the sodium concentrate of yellow mustard is at a good point to where like it helps with muscle fatigue and everything like that and prevent cramping. So I thought that's really interesting.
That's a cool point. But
yeah, I got one thing to say. How did you guys feel? I'm not gonna say his name, but we all know who it was, about the one person's idea that dehydration has nothing to do with cramping. Do we all remember that? Who said this? We all remember this, right?
I do.
So I've said that to so many people, and so many people have like looked at me sideways.
Yeah, it happened to me too, Trevor.
I mean, he genuinely believes that. I mean, I don't know. I'm sure he has evidence. He's not a dumb person. Like, he wouldn't just say that. You know what I mean? Like,
yeah.
I would like to read those articles though.
Yeah, those articles would be.
Maybe we'll have to have him on the show and talk more about it.
Oh yeah.
But all right, does anybody have anything else for our position statement talk that we had? I think it was pretty good.
Yeah,
covered a lot of
I
stuff.
enjoyed it. Besides the technical difficulties, I enjoyed it. But I don't think the viewers will,
Did you guys want
be
to touch
affected
on
by any of that.
Did you guys want to touch on heat exhaustion? I think that's the only one we didn't hit.
Yeah, if anybody wants to, go ahead.
Well, I remember reading this, and this is like a big thing that goes into what we were saying before about IVs, but that's like a big thing for heat exhaustion is like they
Mhm.
recommend IVs.
Yep.
Yeah.
And
IV
that's
treatment
just
to replace fluids.
more of the frustration continues.
Yep.
Yeah.
Even though it's not in our best practices yet because the national regulation doesn't allow for us to place IVs yet, but there's a lot of substantial evidence that fluid replacement is a big part of even if it's heat exhaustion or any type of heat illness. Fluid replacement is one of those big things that we need to do. And with having people, you give them a bottle of water if they have heat exhaustion, you say drink it slowly, but that's not the best way of replacing fluids either. So it's not covered under most education programs yet, but I think it's going to be here soon. So
and I know with both heat exhaustion and heat syncope, you're supposed to like lie the patient down and put their legs up too in like a cool area.
Yeah, in a shaded area.
That helps too. Not just like the hydration part, but obviously the hydration is probably the biggest point that we can push here. But I know that there's other things you can do besides the IV that we can do.
There's always ways around getting to the best practice or what's stated in the data. We have obviously athletic trainers have been around for a long time and they've gotten through everything. So, and we're just trying to advance practice and keep it going for the future. Get some more exciting things to do.
Yeah.
So
who knows what's going to come from everything.
Oh yeah. So that's going to be it for today's episode 2. We're again, putting this on YouTube and Spotify for right now. The Position Statement Podcast on YouTube and Spotify, Discord, Position Statement Podcast, Instagram, same thing, but all lowercase, no spaces. So give us a follow on there, subscribe to the YouTube channel or anything. And especially on the Discord, we want to get some ideas for the podcast from you guys. And
yeah, that'd be great.
Hopefully
comment somewhere. You know what I mean?
Discord,
Anywhere,
YouTube.
Yeah, on Instagram.
We got people looking at it.
There's actually a new clip up on the Instagram. I don't know if you guys saw. I think somebody posted a clip on the Instagram.
What?
I don't know if someone was busy while you guys were talking.
Oh,
Liz is gonna get fried. I just want to let you all know Liz is gonna get fried.
Ah, God. Yep. Here we go. Here we go.
But
some content for the Instagram, so hop on over there, follow that.
I talked to people. I talked to some of our colleagues, and they agree with me. Howie's is number one.
I'm not gonna lie to you. I'm talking to an intern that used to I'm not talking to her in that aspect. Sorry, that came out really weird. But I'm texting her, telling her about the podcast, and she said the same thing. She actually likes Kramer, believe it or not. Yeah, an interesting one there. Yeah, but we I think in the future maybe we'll have some guests on.
Yeah, I want guests.
Yeah, I want differentiating opinion. People from different colleges, you know what I mean? Like this girl went to Moravian and she sutured and does all that stuff. So she went through all that. So it'd be cool to hear, outside perspectives.
For sure.
All right. So give us a follow. We get a subscriber. Make sure you guys are commenting on the different social medias and the YouTube and stuff. We want to hear what you guys have to say. Give us some suggestions.
Topics to talk about.
Yes.
Yep. And tell us how you like the podcast. This is their second time doing it. So anything you guys say will help us in the future. So, well, that's about it for today.
Yeah. Adios. That's a wrap.
I guess we're logging off here.
Yep.
We love you. Thank you for listening.